Hello. Hi, everybody, and hi, everybody online. My name is Gwen Driscoll. I'm the Director of Communications for the UCLA Center for Health Policy Research. Last week, with the fate of hundreds of thousands of young, undocumented immigrants in the balance, the U.S. Senate began an open-ended debate on immigration. That closed without much progress. But the issue is not going away. A must-pass, roughly $1.3 trillion spending bill later this month will again hinge on immigrant-related priorities, protecting dreamers versus building Donald Trump's border wall. The fate of immigrants seems to be a topic that so much else depends upon and makes today's seminar all the more important and germane. But first, a note about next month's seminar. In 2018, over 29,000 women will be diagnosed with breast cancer in California, and an estimated 4,500 will die of the disease. Yet patients and survivors continue to face serious economic, emotional, and structural barriers to care, all while balancing family and work obligations. On March 19th, the center will release key findings from a 2-year study on the obstacles breast cancer patients face accessing care in California. At a noon seminar on the same day, authors Inez Ponce, Associate Center Director, and researcher A.J. Scheitler will discuss 3 of the most pressing obstacles. 1, a need for patient navigators to help breast cancer survivors understand and access services. 2, there's a lack of continuity of care within the very complex system of providers, support services, and insurance requirements. And 3, the particular obstacles facing low-income women, including narrow provider networks and time limits on coverage. Please join us for this critical discussion of how California can better extend life-saving, life-extending treatments and services that enhance quality of life for survivors of this highly prevalent disease. Okay. As for today's seminar, we are recording it, and it will be placed on our website at the address you see at the top of this slide. If you are watching online and would like copies of today's slides, please email me at gdriscoll@ucla.edu. That's that second line there. Please note we'll also have a brief question and answer period at the end of today's seminar that I will moderate, as always. Okay. A common myth about undocumented immigrants in the United States is that they place an undue burden on the nation's healthcare system and particularly the safety net. In 2016, the center was host to Paul Dourgnon, a center faculty associate and a research director at the Paris-based Institut de Recherche et Documentation en Économie de la Santé. How did I do, Paul? Yeah, okay, good. Paul was also a 2016-2017 French Harkness Fellow in Healthcare Policy and Practice based here at the center. So welcome back, Paul. We missed you. Using data from the California Health Interview Survey as well as county stakeholder interviews, Dourgnon assessed how well immigrants are served by California's safety net and what the health outcomes are for immigrants who are able to access services. He will also talk about how California's safety net responded to critical events, such as the Great Recession, the passage of the ACA, and subsequent repeal efforts. He will also compare responses to the undocumented in the United States and those of France. Paul is here to talk to us about these findings at a particularly poignant moment given current events, so please give him a warm welcome.
Good morning. So I'm Paul Dourgnon from France. I think you can hear that, the slight accent. So I'm an economist in France, and I work at the Institute for Research and Information in Health Economics in Paris, where my research mainly focuses on social health inequalities and on access to healthcare services. And today I will talk of a research I undertook together with Nadi Pourat here at the Center for Health Policy Research as a Harkness Fellow in 2016 and 2017, when I studied the role of safety net, county safety net systems in providing coverage to undocumented migrants. So first, as an introduction, I would like to stress why it's important, and more than that, actually crucial, to study migration in order to provide more evidence to the political debate. First, because there is, when it comes to undocumented migrants' health numbers, health access to healthcare services, basically no or only very scarce and non-convergent evidence on what is happening from the point of view of health and healthcare utilization. There is nothing in France and not much actually in the US, or not a lot in the US. Second, because of the complexity, undocumented immigrants are not an homogeneous population by any mean. They differ very much according to country of origin, according to economic status, reason for migration, reason for being undocumented actually, and migration trajectory, histories that in turn have an impact on their health status and coverage. And third, and that's maybe the most important reason, it's a very sensitive ethical issue, and ideology often dominates evidence. It's true in France, and it's true, I think, in the US too. And a good example, I think, is the so-called migrant crisis. I think we all heard about migrant crisis, current migrant crisis in media. Well, there is no such thing as a migrant crisis. It's not a crisis. If you take a look at the determinants for migrations in the demographic models, well, what the main determinants will be disparities, economic disparities between sending and receiving countries. The other determinant would be the size of diaspora groups in the receiving country, and the third would be political instability in the sending countries. Well, there is no reason to think that any of these determinants will change or fade away within the next decades. So it's not a crisis. You can call it a series of crises, or actually a continuous inflow, which trend has no actual reason to change in a short, mid, or long-term perspective. So how does it come that French economists come to the US to study how well or how badly undocumented migrants are treated in California? Well, there are many common issues in France and the US. First, both countries have actually long histories of immigration. It's interesting, I think, to keep in mind that France remained an immigration country. I mean, a country that received new migrants, while all other European countries were sending millions of them to the US during the 19th and the beginning of the 20th century. And so both countries have actually implemented migration policies along the years, not the same, but still. And of course, migrants are not coming for the same reasons and not from the same places, but still, they represent in both countries a significant part of the resident population and a significant issues in terms of healthcare coverage. Of course, when I came to the US, my general idea of the project was that after the ACA, that would substantially reduce inequalities in access to healthcare services among legal residents. The next step toward universal coverage was to include, in a way or another, undocumented residents. Well, then the presidential election happened at the beginning of my fellowship, and then the new question was how to deal at the local level, so the county level actually, or the state level of California, with expanding coverage to undocumented migrants in a context otherwise, I mean a federal context that was otherwise very unfavorable to the very presence of these immigrants. Just as a reminder, California hosts, it depends a little bit of the estimations, but around 2.5 million undocumented migrants, among which 2/3 approximately are uninsured. Many of them are in Los Angeles County, but it varies across counties. And then it's a pioneer state, and I will come back on this point, since a few counties have actually implemented very innovative safety nets programs that cover or try to cover or expand coverage to undocumented migrants. And I will explain how and how well they do and how they could do maybe a little bit better. So the general idea of the project is to build on existing evidence. I mean, there's been many papers that have been written actually at the center on immigrants and undocumented immigrant access to healthcare services in California, thanks to the CHIS survey. but to add a county-level perspective and a safety net perspective, and so to study undocumented migrants' utilization of healthcare services, and also the programs, meaning the county-level safety net programs that help or actually do not help them access these services. So I will take a few minutes to draw a general picture of what is already known about undocumented migrant needs, so that we start from something that from existing evidence, and then I will describe what's happening in France in terms of how many undocumented migrants, where they're coming from, how they're covered, what are the current debates, what are the challenges for policymaking and for research, and then I will move to California and talk about safety nets and undocumented migrants coverage in California. And I will do so based on qualitative study, stakeholders interviews, as well as a quantitative approach based on the California Health Interview Survey. Just one slide on what we know on migrant health status and healthcare needs. When it comes to migrants, again, the main important things to remember, I mean, undocumented migrants, is that it's not an homogeneous population. So when one wants to conceptualize or think about what may differ, why my migrants' health may differ from natives or legal residents' health, there will be three main streams of causality network. The first one has to do with social determinants of health, but that's the easy part. So migrants or undocumented migrants may have social characteristics that in turn may impact their health, and so create differences between them and other legal residents or natives. So it could be access to health insurance in the US, could be living conditions, work conditions, etc., etc. This has been addressed like in thousands of papers in the literature. Well, there are two main other streams of causality that may explain why, even when controlled for these differences in social and economic characteristics, migrants still differ from others regarding their health status and regarding healthcare access to healthcare services. First, there is what I call a main sort of acculturation pattern, and this has nothing to do especially with the undocumented migrants population. It actually has been studied among also regular migrants, but it could absolutely apply to undocumented migrants. So a few things. First, so it's the general idea is of an acculturation pattern. So there is this, what the literature calls a rapid transition effect. So the idea is that migrants have lower all-causes chronic disease mortality than natives. It's not true for every chronic disease, but it's a general picture again. They have a higher mortality from infectious diseases, and that these differences wear off with time of stay, and studies tend to show that after one generation, they just fade away. Another set of hypotheses that has very much to do again with acculturation and acculturation pattern. This mostly with health behaviors and has been very well described, at least in the US and Canada. It's called healthy selection effect or healthy migrant effect and unhealthy assimilation effects. So the idea is that migrants are healthier people that are migrating are healthier than they are those who do not migrate, because migration is difficult, and then most of them are seeking jobs that are very demanding physically, so they are healthier, and then along the years, their again health or health behaviors tend to converge to those of the natives. So it has been very much well proven with body mass index, obesity in the US and Canada. It's more complex than that in Europe. Such patterns have been shown to be more complex in Europe, but still that's the general idea. There are other effects that pertain to the country of origin. We can think, of course, of risk exposure, health literacy, and then the health system, does it exist, how it is, and what is access to, how did migrants really access to healthcare services in their country of origin, and then lastly, effects that present to the country of arrival. So loss of social network, this has been again very well looked into. Access to information, I mean administrative information, language barriers, and discrimination. It has been a little bit assessed in healthcare, not much, but a little bit. And then a second stream of causality has to do with a completely different population, which I call refugee, although because I just don't know exactly how to explain who they are. But basically, these are Jews who fled their countries for economic, political reasons and just managed to get away into host countries. So this is clearly has much more to do with Europe than the US, but still there's something there. So these people, this subgroup has actually very specific health patterns. So I mean, if you have ever visited a refugee camp, you know very well what I'm talking about. I think you haven't forgotten that because it's quite striking. So injuries, infectious disease, dermatology problem, reproductive health and perinatal health problems, mental health related to PTSD, anxiety, isolation, whatever you have that is related with human trafficking, rapes, assaults, anything that can have happened during the migration, usually actually from the Middle East or Africa to Europe. And again, this is very specific to this subgroup of population, but we can see that the needs can vary dramatically across migrant subgroups. So let me welcome you to France and discuss a little bit what we know and what we don't know actually about undocumented migrants there, undocumented migrants coverage. And so that's a nice slide. I mean, so I know some of you like very much France, so they will recognize the two pictures. This is La Défense, so this is Paris, or the neighbor of Paris. It's not exactly Paris, but it's very close to Paris. And that's the business district. It's the second largest business district in Europe, I think. So every day you have 160,000 salarymen that are converging to this place to work and earn some wage for their family. And so converging meaning using public transportations, highways, whatever else, that all of them have been constructed under the soil, actually. Well, that's the nice picture. What you don't see on the picture is that just beneath the soil, actually, in remote places like abandoned tunnels and others, you have 2,500 Afghans that are living there. And actually, it's an estimation I got. I don't know if it's... Oh, I'm sorry. I'm sorry.
You're not Mike, so.
Where's the microphone?
It's built in there.
Yeah, okay, thank you. Sorry about that.
That's okay.
Okay, so you have 2,500 migrants from Afghanistan living here. It's recent. I discovered this 2 weeks ago. And it's quite striking because, well, basically they're invisible. Well, let us move to the east part of Paris. This is the Bois de Vincennes. So it's a very lovely place. Again, you can see there are 19th century very romantic buildings. And if it's sunny, it's a really nice place to go for a run on the weekend. So I suggest you go there for a run, but you extend your run to the left, to the east part of the place, and then you will bump into villages, like campments, with hundreds of homeless and undocumented migrants, mostly from Eastern Europe and Russia. These campments have no running water, no electricity, no sanitaries, and of course no access to healthcare services. So that's the invisible part of the phenomenon. Now let us come to the visible part, at least in the media. These are, I think you know about this. These are the main campments along the Channel, Sea that separates France and the United Kingdom. So these campments, or barracks actually, are hosting migrants that are hoping to cross the Channel and settle in the UK. So the one on the left are Grande Sainte. This is very close to Dunkirk, and so to the north of the Channel. And the other one is the largest one. It's called the Jungle of Calais. The first one was hosting about 2,000 migrants. Really depends. It changes every day. So it was supposed to be removed, but then they came back again. And same for Calais. It was supposed to be removed, but at the end of the day, it's still there. So these campaments, and I could have shown you pictures of Paris actually, and you could have seen campaments under the metro lines, not everywhere, but to the northeast of Paris. That's the very visible part of, and the shocking part of actually, the shocking pictures of migrants that is very present in the media and in the public debate in France. So, what happens to you when you're a migrant and you're migrating illegally to France? Well, as you may know, France has universal centralized, more or less centralized, but universal healthcare coverage, meaning that 100% of the legal population is covered by the public health insurance. And it's a very centralized state, meaning there are not many policies that are done at the local level. Migrants, illegal migrants are actually entitled to a state medical assistance, which is basically a public health insurance of its own that is funded by the state. So in order to be eligible for this insurance, you have to prove you've been living on a permanent basis on French soil for at least 3 months, and that's it. And then you benefit from basically the same basket of treatments, I mean, of benefits as the rest of the population at no cost. It's a means-tested scheme, meaning that you have to prove that you earn less than a certain threshold, and then you can access, theoretically at least, to most, that is actually every type of care, inpatient stay, primary care, prevention, everything. Well, that's very generous. It looks very generous. Is it very costly? Is it sustainable? Does it work? Well, I will start by the does it work question. There are plenty of problems around that. First, access to information. It's very difficult to understand eligibility process and limits to eligibility. Even I do not understand everything. There are many administrative barriers in the sense that street-level bureaucrats may have incentives for not giving access to the migrants to this kind of insurance. There might be also, for those who are covered by the scheme, refusals from certain medical doctors for reasons that pertain to not really to basic racism, but well, they don't want them in their practice because they may look different from the other patients, and other patients may just go to see other doctors. And because it's a fee-for-service payment based, I mean, they have incentives. They may have incentives, or they may prefer not to have these people in their practice. And then the other thing is that the healthcare services in France are really not ready to welcome or to treat this population, meaning that there are no systematic translation services, there is no training for the medical workforce, and there is no incentives again for the medical workforce to be representative, I mean diversity representative. So there are limitations there, clearly, but maybe the strongest limitation is that there are no statistics, there is no evidence. That's really, for me, it was the most striking difference between France and the US. In the US, if you take a look on internet, you can find tons of estimates of the number and distribution of undocumented migrants, and even debates, methodological debates. The EUW Center will say something, others will say other things. In France, we have nothing. Actually, we don't know how many there are. So meaning also that we don't know how many eligible migrants do not actually get access to this insurance. We have no idea. I'm working on it at the moment, but so far we have no idea on that. So what we know is that about 300,000 have so far enrolled, and these numbers are increasing very fastly. And it represents, as of today, about 1 billion euro a year. And again, it increases very fastly, like you can see on the slide, plus 40% increase in expenditure. I mean, so it's public expenditure in about 6 years, from 2009 to 2016. What I didn't talk about, and it is also very interesting, is the residence permit for medical reasons. The idea is that if you're in France illegally, and if you're coming and if you have a condition, if you're coming from a country where you cannot be treated for this life-threatening condition, you can apply for a specific resident permit that will protect you from deportation. That's very generous. The interesting thing again is that there are basically no statistics on the scheme. So it took me time to find these 30,000 people included in the scheme. I'm not even sure it's the right numbers. There are no economic studies of any kind to see how the expenditure are moving, increasing, decreasing, whatever. So we have no idea. What we know is that, again, street-level bureaucrats are being received orders to sort of block access to this specific residence permit, to avoid having thousands of migrants or thousands of migrants actually applying for it. So that's very interesting again, because what it says basically is that decision makers, when it comes to undocumented migrants, do not want very much to deal with evidence, because they know that a part of the public opinion is against these policies, and still they know that these policies are necessary in terms of public health and other points of view and dimensions. So in this slide, I just listed the very recent, by recent I mean last 4 months basically, public controversies we had over this scheme. What you have to keep in mind is that there is absolutely no controversy in France and in Europe about universal public health insurance. This is considered as a public treasury that we have to cherish and protect, etc., etc. The only controversy when it comes to political discussion is about the head medical data. Sorry, I forgot the English name I gave to it. I mean the scheme, the coverage of undocumented migrants. That's the only thing that is really divided among policymakers and in the public opinion. So the Senate Finance, I think it was last October or November, issued a report saying they had this objective to reduce the cost of this scheme by 300 million, which basically means nothing, because you cannot cut public expenditure, public health expenditure like this. I mean, migrants will continue to go to emergency room, and it will probably cost more than that. So the best way to cut this cost is actually to allow migrants to access primary care services and preventive services. But of course, they don't understand anything about these issues. Again, that's the problem of evidence-based or not evidence-based policy making. At the same time, actually, the National Committee for Ethics published a statement that was going the opposite way. So they were saying basically that, again, the undocumented migrant scheme would represent a marginal weight in the overall public health expenditure, which is true. It represents basically about 0.5% of total public health expenditure. And it stated that health is a right, and more should be done to facilitate access, because they knew that there were barriers in access to this coverage. While the main NGO in France that is working with undocumented migrants, they have opened a few facilities that deal especially with undocumented migrants around Paris and other places, which is Doctors of the World. It's a very large NGO. It's worldwide, actually, and issue a report, and they are surveying their own patients, and they were pointing real strong barrier in access to insurance for these migrants, and they were advocating for incorporating the medical data, which is again the scheme for undocumented migrants, to mainstream public insurance. So you can see that, I mean, it's not only that there are debates, there is a very strong divide in terms of what should be done considering immigrants, undocumented immigrants in France. And along the years, I mean, for the last 10, 12 years, conservative and right populist parties have been constantly pushing to eliminate the scheme. I mean, there is no, again, any evidence behind this position. It's mostly an ideological position. So that's the general picture I wanted to show you about France. And now I'm going to move from a very centralized country with a universal public health insurance to a very much less centralized country, the US and California, with no universal health coverage, and try to understand better how county level programs may help to expand coverage to undocumented migrants. So, just to clarify a little bit about the project, the content of the project. So the main question I had was I wanted to understand better how county policy and healthcare, how the county level policies toward undocumented migrants, and secondly, I wanted to provide an analysis of healthcare services utilization among undocumented migrants, that is, as compared to legal migrants, as compared to natives, with an emphasis on county-level factors. Just a few words on the context. I think you know this better than me, but still, I mean, we know that undocumented migrants had been excluded from actually, to my knowledge, all main federal reforms or reform attempts along the year. They had been excluded from the Clinton's universal coverage plan by the mid-90s. They had been excluded from the Obamacare in 2009. And while actually the estimated number of undocumented migrants was increasing very strongly from 3 million by the mid-90s, again, at the moment of when the Clinton's plan was presented, to about 11 or 12 at the end of last decade. The difference is that, of course, today it faces a federal context that I view, at least that's the way at least it is viewed in France and probably in the rest of the world outside the US, as very hostile to any measure that would be seen as a pulling factor, meaning an incentive toward more illegal immigration. So the study is based on a qualitative and quantitative analysis. So the qualitative approach consists of interviews with stakeholders, that's foundations, California Department of Healthcare Services, county departments, of course, as well as quantitative analysis that I realized from the CHIS, the California Health Interview Survey, from which I pulled 3 years in order to have a larger sample of migrants, while the county level context will remain approximately unchanged. So I could try to assess county level effects. Just a word on the methodological challenge, not much. Can we study undocumented migrants from general population survey? That's a good question. We all know it's under the radar population. There are sampling bias. Obviously, there is no registers for this kind of population. Second, and again, that's an evidence that comes from every country, a very strong rate of refusal to participate to surveys from undocumented migrants, and third, response bias. Migrants may tend not to properly answer to questions regarding their legal status in the US. Even though we managed to have a significant sample of 1,500 migrants, and I will show you just a few results. It's difficult to read, at least for me. Just descriptive results on the undocumented migrant population in California. These are adults only, okay? From what we see from the CHIS survey. So we have a small majority of men, 53%. It's a rather young population. 2/3 approximately are less than 40 years old. And it was a surprise for me, the proportion of undocumented migrants that are married with kids is largely higher than in the rest of the resident population. And of course, they have very high level of poverty. 46, nearly half, are living under the federal poverty line, while it's only 14% of the rest of the population. English proficiency, 3/4 have low or non-English proficiency. Health status, well, that's an interesting result. That's subjective health status. That undocumented migrants in California tend to assess their own health as generally as poorer than other Californians, and it's even stronger. The difference is even stronger when you take into account differences in age and gender. Care, usual source of care. A third of undocumented migrants do not have any usual source of care. Again, that's a very strong number. They also tend to use less the emergency room services, but more often to rely only on emergency department as their usual source of care. So it's a sort of, it's not exactly a paradox, but it's an interesting result, I guess. They also rely much more often on county level facility as usual source of care. It's important to remind that they represent 6 out of 10 uninsured in California, and as compared to other uninsured, they have worse health status and they have less access to healthcare services. So as I explained in the former slide, they rely much more on county level facilities such as clinics and community centers for their usual source of care, especially in non or peri-urban counties. But I couldn't assess any strong impact of the types of safety net programs. I will explain later how I try to characterize the safety nets, which appear all non-significant. Two main reasons for that. The first is the sample size are too small, unfortunately, and the second reason is that the programs themselves are undersized. As an example, the My Health LA safety net program covers about 150,000 undocumented migrants in LA County, while the total number of undocumented migrants without health insurance is rather around 600,000 to 800,000 individuals. So, of course, the overall effect of these safety nets is difficult to assess from general population surveys. I will skip this one. So a little bit more about counties and provision of care toward undocumented migrants in California. And this comes mostly from the qualitative approach that was fortunately much more rich in terms of results than the quantitative approach. So what you have here is just a map of California counties, and in yellow or orange you have the County Medical Service Program county, that regroups counties from rural areas, and in red you have two counties. You have the LA county and you have the San Francisco counties. These two counties are clearly ahead of the others in terms of providing coverage to undocumented migrants. I will describe these counties a little bit later. So Californian counties have been since the mid-30s, I think it's since 1933 or 5, responsible for providing care to low-income Californians, meaning residents of California, that had otherwise that were not eligible to any federal or public scheme, basically medical. So, of course, the question of providing care to undocumented migrants was treated very differently across the counties. And so they have evolved in a very large variety of ways along the year. And two innovative programs were really set up in California, actually by the same people. That's interesting. First one in San Francisco, HealthFit San Francisco, was launched in 2007. And it's, again, of course, a county program that provides care to residents regardless of immigration status. The income threshold, it's a means tested program, of course. The income threshold is quite high. It's about around 400% of the federal poverty line. It charges a participation that depends of the income, of course, and it's it regroups a mix of public, non-profit, and for-profit providers. The My Health LA was actually built after the San Francisco program by the same designers, but it's a bit different. It's a no-cost healthcare program that was launched quite recently, by the end of 2014, and that provides care again at no cost for low-income uninsured county residents, and regardless of immigration status. So the idea is that there is no out-of-pocket payments or users fees, and it regroups as many as as of today, I think 200 medical homes, a network of medical homes that provide a primary care and preventive care to its enrollees. Again, that is coming from France, where everybody is very central, everything is very centralized. It was really interesting to see how agile these organizations are and how they could adjust to a very changing and rapidly changing environment. So what the stakeholders described me was that first, I mean, I wanted to know more about how their organization had evolved along the year and the last decades, basically. And so they described that they had to change very much after the Great Recession, which caused many to lose their employer-based insurance, and also because eligibility to federal programs such as Medicaid changed also at the same time. And so the number of uninsured increased, while at the same time public financing was decreasing. So that was very hard times and difficult moment to adjust for Californian counties. The other phases, significant phases, was what happened after the ACA implementations. So the ACA basically decreased the uninsured rate in California from 16% to 11% in about a year. So it's a reduction by about a third of the numbers of undocumented residents in California. So clearly, again, the counties had to adapt, and they had basically to make a choice between, or they could do actually become the two of them, but a choice between becoming providers of choice for the newly insured from medical, or they could try to remain, to stick to their long-standing mission and to keep being the provider of last resort, being actually focusing on immigrants. And that's where My Health LA and Healthy San Francisco took different positions and directions. My Health LA has 10 minutes. Thank you. My Health LA has de facto become a provider for mostly for undocumented residents. Why? First, because the number of undocumented migrants in LA is very important, and the second reason is that actually sticks to its initial threshold, which is 100% and 138%, sorry, of the poverty line, which is the medical threshold of medical, meaning that all those who would keep, who would still be eligible for the scheme would have to be undocumented migrants. So I didn't have any statistics, and I don't think they have, about the percentage of undocumented migrants they have among the people they cover, but it should be around 100% as of today. At the same time, Healthy San Francisco saw a drop in the number of its enrollees, but then the percentage of undocumented migrants was much lower in the area. Sorry.
Just a quick question. Your last bullet, 47 out of California's 58 counties had expanded its eligibility to what?
To undocumented migrants.
To participate
in safety net programs. Yes. Sorry about that. So at the same time, Healthy San Francisco took a different direction and decided to stay the provider of choice of its former enrollees, due to the fact, probably, that's my understanding, that they had lower numbers of undocumented migrants. At the same time, and during the same period, many counties tried to move toward more coverage of undocumented migrants, and as of mid-2016, a majority, that is 47 approximately, of the California's 58 counties had started to expand eligibility toward undocumented residents. It doesn't mean that all undocumented residents, of course, are covered now. This is what I explained just before. Only a very small part of them, because all these programs are just starting now, or about to start, and others, such as My Health LA, are still very much undersized. And so the first phase is well, nowadays, so the post-election challenges, and first county safety net stakeholders explained me that they had to understand better and to anticipate what was to come from the White House and Washington Hill. Actually, there was the repeal and replace. There was Trump care, that just popped up, and more anti-migrant policies that were implemented or said to be implemented along the months and the years, and that created a sort of instability in the sense that they really didn't know what was to come the next day. And all of them explained me that they wanted to keep the pace of coverage expansion and position themselves actually in a way in resistance to the federal level, explaining again that California was a sort of stronghold, that it was strong enough, economically speaking, to resist federal policies, and that the new situation was creating, and that came a little bit as a surprise for me, but that creating an opportunity to search for alternative sources of funding and work toward actually more coverage by strengthening cohesion between the counties toward this common objective. And this is something I found, at least among most of the counties I tried to interview, is that there is this idea to expand coverage to undocumented, and now they are trying to find a way to do it, although the context at the nation level is not very migrant friendly. So I don't know exactly how much time I have, maybe 5 minutes, but I think I already said much of that. I'm going to skip this one. What are the lessons of the French case and of the study I undertook here at UCLA regarding county level programs? I think there's a number of strengths that it's important to focus on. First is that these county level programs are very resilient. Second, they're super nimble, actually very agile programs, and they can adjust to a very otherwise hostile context. Third thing is that they are very innovative. That's again a strong difference between France and the US. In France, usually innovation comes from the top of the pyramid and down to the bottom. And it was very interesting to see that these forms of local organizations could provide much more innovation and social innovation than what was coming actually from the top of the pyramid. The other strength is the availability, or at least the existence, of data and the richness of research regarding undocumented migrants in the US, and especially in California, which again comes as in opposition at what is happening in France. Limitations, well, there are. Probably a question of efficiency. Is it efficient to provide care and have these very scattered health organizations in sometimes very, very small counties? It's unclear, but I think it should be assessed a little bit more. And in my opinion, it is clear that the overall effect on social health inequalities may not be very significant, or could be actually increased by more wider, maybe state policy or maybe federal policies. It is quite known that local policies can produce actually more inequalities than even though they wish to reduce them. Just a few conclusions. I would like to insist on. When thinking of migrants and undocumented migrants policies, I mean health coverage policies, it is important to keep in mind that keeping migrants outside the health system is first unfair. It's actually cruel because it's painful and it's actually sometimes even lethal. It's inefficient for the health system because undocumented migrants do not overconsume healthcare services. And second, because letting migrants accessing only ED care is actually very costly and much more than letting them accessing primary care as other residents. So it makes really no sense in terms of efficiency for the health system. Third, it's economically completely inappropriate. I mean, migrants represent sometimes 10 to even 30% of employees in certain sectors of economic activity. You can think of the construction sector, restoration, catering sectors, and others. Agriculture, of course, also. And you want employees that are in good health, and this has been, I mean, super widely shown to have a strong impact on economic outcomes. So it doesn't make any sense, again, from an economic perspective. Then it's potentially harmful for the population health itself. We call this usually externalities, or you can call this epidemics. The idea is that if you allow a certain number of people to be kept to live in an area, but to be kept outside the health system, then it is very likely that if they're in poor health, this health can migrate actually to the rest of the population. This has never been really proven on a large scale, like at a country level. But this is something we have to keep in mind. I mean, universal health coverage is for something. Actually, it's the idea is that you have to protect everyone in order to have the whole population in good health. So that was my main comment. I think they apply to any developed countries today. I'd like to thank the Commonwealth Fund, of course, who funded my fellowship, and Nadi, with whom I had the pleasure to work with. Thank you.
Okay, so we're going to do a quick Q&A for those who cannot stick around. If you have questions, please email me. Again, it's gdriscoll@ucla.edu, and I will make sure we get them answered. But if you folks online and here in the room can stick around, we'll take a few questions. The way I like to do this always is to take one from online, one from the room, and just go back and forth. So let me start. The online folks were quick to ask questions, so let me start with them. The examples of My Health LA and Healthy San Francisco are kind of, as one participant said, impossible for smaller counties to implement. Are there examples of medium or small county innovations you can point to?
That's a good question. When I interviewed the stakeholders that was in late 2016 for most of them, they explained me that they were trying to expand these programs to mid-sized counties. I don't have the name of these counties, but I know they are trying to. And again, the interesting thing is that it's not the story of a large change at the state level. It's about individuals that have decided they would change and actually implement the social innovation at the county level. So they did the San Francisco program, they did the LA program, and they're working on other places to do it. The question about rural counties is a good question, but I mean, again, from a foreigner perspective, it's very difficult to understand how this sort of puzzle, this sort of very heterogeneous administration level can be efficient politically, economically, or in any ways. I mean, the smallest county in California, I think, is Alpine County. They have, it's east of San Francisco. Wait, you know this better than me, but they have like 1,200 inhabitants. What can you do at this level? Well, basically nothing. You have to regroup. And the largest is Los Angeles. It's 10 or 11 million, so it's larger than most United States. So basically, county level approach from a rational, very French perspective has not a very strong meaning. I mean, maybe the idea would, rather than change the policy, the local policy would be to change the way these counties are organized. I mean, counties themselves. I mean, this administration level seems
Is there a question from the room?
not to make sense anymore.
Since you said something about local policies may lead to more inequality, and I was just wondering if you know of any like beneficial, helpful ways that can help expand healthcare in communities. For example, right now in the United States, where federally speaking, it tends to be leaning more of an anti-immigrant sentiment. So I guess my question is, did you see anything in your research that could perhaps benefit the expansion of healthcare for undocumented immigrants?
To my point of view, the thing that would really, I may be wrong on this, but help expanding coverage would be to put more emphasis on the economic consequence of covering undocumented migrants. I mean, if you do cover them, I mean, there are clear positive economic outcomes. I mean, this should be a very strong incentive in the US, I guess. So that would be the main, I mean, yeah, that would be my
So
main.
again, from online,
Sure.
this question came up towards the beginning of your presentation. What evidence is there of how acculturation and selection patterns vary by documentation status?
Actually, all that has been done on acculturation, to my knowledge, has been done on overall migrant population. So what I provide in the slide on causality, streams, etc., is what we know about migrants that we think is transferable to undocumented migrants. So there is nothing that has been done, again, to my knowledge, specifically on undocumented migrants, but for a very good reason, is that they are very difficult to follow. I mean, the idea is that can you follow, from a researcher point of view, an undocumented migrant from either his or her arrival to the next generation? This is virtually impossible.
Hi, Rochelle Wenger with Dignity Health. I agree with you that the economic argument is something that is very important, and it clearly kind of shows what the benefits are to a county, to a state, to a country. I am particularly struck by your conclusions that point to the unfairness of it and the cruelness of it. And I am thinking that, you know, we need to really address the ideological barriers and challenges that are preventing us from getting to where we want to go. And so I'm just wondering, from your research and in the way that you've really approached this issue, how we might be able to break down some of that ideological divide. Because I don't think the economics is good enough, actually, because it makes clear sense. The numbers are there in our favor, and yet that unfairness and that cruelty still hasn't been addressed.
Thank you. That's again a very good question. I think the question of the ideological divide is, well, apart from healthcare question, is the main question the US has to address today. Yes, cruelty, I mean, that's a kind of paradox, because the idea is that because it's inefficient, the system is spending more money so that some subgroups of people cannot access healthcare system. That's what I call cruelty, I mean, because it's expensive. I mean, it will be probably less expensive to allow them to access. Well, there are many things that have been written on that. I mean, that deals with Protestant ideas and others, but I'm sorry, I don't have I mean, because I could talk about evidence, but even the word evidence-based today is not shared among the population. So I'm sorry, I don't have a better I don't have a better answer, but that's the main question. That's yeah, how to reconcile the two sides. I agree. I agree. And that's also a question for research too. I mean, because I mean, we don't do research for research. We do it because we want to improve the system. But that means also responding to public demand. And what is this public demand here? I mean, in France too, actually. What's the public demand? It's unclear. I mean, at the Californian level, it's clear. I mean, we want more. There's a need. The public demand, to my understanding, is that there is a need for more coverage of undocumented migrants. But then at the federal level, it's completely another story. It's that we need less undocumented or less migrants. So how do you deal with this contradiction when you're doing research? Like when, you know, the norms of public justice are just completely opposite across the political border. It's not a question of adjustment.
We have time for one more question. This one sort of combines a number of questions we've been getting from the online folks. Regarding the 47 out of 55 California counties expanding eligibility to undocumented, what does expanding eligibility look like? How do CMSP and basic safety net counties incorporate undocumented residents when federal policies are at odds with state policies and full scope Medi-Cal is usually limited to legally present immigrants?
That's a good question. So far, and again, from what I collected on the field, I understand that it is still being discussed, but it's announced. So the idea that they are on the move to expand coverage. The real question is, to how many migrants? I mean, you can always expand eligibility, but if you don't have the money to cover the people that need to be covered, then it doesn't mean much. That's the main question. Actually, is again, in my opinion, is not the ways to expand coverage, but the money you put there. I mean, My Health LA is a much bigger program, but still it doesn't cover even the half of the people it should cover in order to provide a real public health policy, meaning police, actually.
Okay, I'm sorry, we're over time, but again, please send me an email and I will get your questions answered. G. Driscoll at ucla.edu. Thank you so much, and thank you to our speaker.